Hello, my name is Wendy. I am a Urology Oncology Clinical Nurse Specialist and welcome to the online Da Vinci Robot Prostatectomy presentation. This presentation will be split into chapters for you to access at home in the future. The presentation is a replication of the talk we deliver to patients to prepare them for surgery. This presentation will cover the following topics: an overview of the prostatectomy with pictures of the prostate before, during and after surgery, and brief description on the history of robotic surgical system. Your potential treatment options, the advantages of robotic surgery, a comparison of our robotic prostatectomy results versus the open method, what to expect on the day of your surgery, what to expect following surgery, discharge information, continence, erectile function, physiotherapy, and follow-up. The next few slides will be a series of anatomical drawings of the prostatectomy. This is an image of the prostate before the prostatectomy. You can see the prostate is connected to the urinary bladder to the base of the urethra and sits in the front of the rectum. Also visible here are the prostatic nerves, seminal vesicles and pelvic lymph nodes. Here is an image of the structures with the prostate removed. Following removal of the gland, the base of the bladder is surgically attached to the urethra. The attachment of these two structures is called the anastomosis. This is a picture of the catheter in place. You will notice the catheter is held in place by an inflated balloon. The catheter is inserted during the surgery. The first prostatectomy was performed in 1904 by Hugh Hampton Young. The robotic surgical system was developed by NASA and the US Military of Defense for use in remote battlefield settings. Robotic surgery was popularized by Henry Ford Hospital, Detroit in 2001. Systems are only used in high-volume centres due to the expense of each machine costing £1.5 million and yearly maintenance of £100,000. In June 2014, there were 3,102 systems worldwide. In May 2011, the Da Vinci robotic system was introduced at East Kent Hospital University Foundation Trust, and the Prostate Forum commenced in June 2011. Kent and Canterbury was the first hospital in south east of England, outside of London, to offer this advanced treatment option. Your treatment options should have been discussed with you by your urologist or oncologist. Depending on your age, PSA blood test, type of disease and other health issues, radiotherapy, brachytherapy, surveillance or hormone therapy are all treatment options. However, this type of surgery is only chosen if we feel it is the most appropriate treatment option for you and you are happy to proceed. The robot is controlled by the surgeon at all times and does not work independently. The robot is connected to the patient and very small instruments are inserted through small surgical incisions, keyhole incisions, in the abdominal wall. The surgeon sits at a separate console and carries out the operation without touching the patient. The surgeon has complete control of the robot at all times. The Da Vinci system enables keyhole surgery. This reduces wound healing time. It provides magnification of the area with 3D high definition, which gives the surgeon a more comprehensive view. The instruments rotate 360 degrees, which increases the percentage of cutting angles available and eliminates any tremor. 5mm instruments are used, resulting in finer, more precise and delicate dissection. The advantages over other surgical approaches include fewer complications, fewer proven infections, less pain, quicker return to activities, overnight hospital stay, shorter overall catheter time, lower intraoperative blood loss, earlier return to work and normal activities, and without a large incision, there is a cosmetic benefit. Here is a comparison between the open and robotic surgical method. The measures compared are detailed on the left of the slide. The best method is highlighted upon the right. You can see that the robotic method is superior in all measures apart from the operative time. The operative time is slightly longer in robotic surgery because this incorporates the time it takes to position the patient and the robotic system, which is a rigorous process. East Kent Hospital is a urology foundation centre of robotic training. We have completed over 2,000 prostatectomies with one of the shortest recovery times in the country. These are the results of an audit of 148 patients 2 weeks after their surgery. 42% stopped analgesia before or at 1 week. 23% were pad-free or using a safety liner. 24% were using 1 to 2 pads in 24 hours. 11% had returned to work before their 2-week follow-up. 35% felt they were at 80% activity level, and only 4% reported a wound infection. Following the procedure, you will experience the following: bruising of the abdomen, scrotum and penis. We advise you to buy supportive underwear to wear for 2 to 3 weeks to provide some support to the genitalia. It helps to reduce swelling post-surgery. Abdominal tenderness and bloating. This can last for a few days after discharge and settles once the bowels are opened regularly, to be discussed later in detail. Bladder spasm and catheter discomfort. As the body adjusts to the catheter, men can experience spasmodic cramp-like pain. The pain is caused by the bladder trying to squeeze out the balloon. Hematuria, blood in your urine, visible 100% immediately post-surgery and can last up to 6 to 12 weeks. Facial swelling. You are positioned head down for the procedure to gain access to your pelvis where the prostate is located. This can cause swelling around and including the eyes. Do not rub your eyes when you return to the ward, as this can cause very minor damage. This will quickly resolve once you are returned to the correct position. Erectile dysfunction and urinary incontinence. Both of these side effects will be covered in detail later on during this presentation. Following surgery, you may experience the following: constipation. Commonly it occurs as a result of medications you will have been given during the anaesthetic and surgery. You will be given medication to prevent this. Urine infection. This rarely occurs, but if you notice any of the following symptoms: cloudy, unpleasant urine, burning when you pass urine, have a high temperature and/or loin pain, contact your GP. Wound infection. Uncommon and can be treated with oral antibiotics. Symptoms include pus-like discharge from wound site, redness and heat. Lymphedema. This is fluid collection around buttocks or legs and ankles. This can last up to 9 to 12 months and in rare cases is permanent. Shoulder tip pain, caused by compression of the phrenic nerve, a nerve in the upper chest compressed due to the head down position and inflation of the abdomen, causing referred pain. This usually resolves in a few hours. Inability to pass urine, the overall risk being just 1.5%. Poor flow, this can occur soon or many months after the operation. It is caused by scarring of the urethra. It happens infrequently and may require a minor operation to treat it. Rarer complications can include the following. Port site hernia, which is when the bowel protrudes through the muscle wall close to the wound. This only has a 1% overall risk. Blood transfusions. There is a less than 1% risk of bleeding, leading to this being required. Damage to adjacent structures. This can include the bowel, rectum, bladder, blood vessels or ureters, or even the nerve supply to the legs. All of these are very rare and carry a less than 1% risk. Deep vein thrombosis or clots in the legs. There have been no occurrences of this in our trust, but they have been reported at other centres. We provide medication to prevent this. Retention of urine, where you are unable to pass urine, and blood in the urine. Both may require admission to hospital and you should seek medical advice. There is a less than 4% risk of readmission following this surgery. You will be asked to attend Preassessment clinic, where routine blood tests and an ECG are taken. An assessment for your fitness for surgery is made and you will provide a urine sample to rule out a urinary tract infection. At this appointment, you will be given clear instructions on when to stop eating and drinking before your surgery. You will be advised to arrive at the hospital early in the morning and report to Clark Ward. The nurses will allocate you a bed. The ward staff will take your blood pressure, temperature and pulse. They will also provide you with a surgical gown and fit you with anti-blood clotting stockings. You will be reviewed by your anaesthetist and surgeon, who will gain your written consent for the operation. You will have an enema administered before the operation to make sure your bowels are clear. You will be provided with a medication to reduce the production of stomach acid called a protein pump inhibitor. If you take one normally, let the ward staff know. We will take a PSA blood test before the procedure and we'll ask you to fill in some pre-operative questionnaires that will have been provided to you before the surgery. The operation lasts between 2 and 3 hours. Once completed, the surgeon will contact your next of kin to update them. You will be given pain relief before you wake up by the anaesthetist. Local anaesthetic will be used in your wounds and bladder. If you are in pain, please tell the nursing staff so they can give you pain relief. You will also have a drain inserted in your abdomen to remove blood and fluid that would otherwise build up internally. This is removed the following morning. You will have 6 keyhole surgical wounds. The dressings ideally should remain in place for 48 hours. Do not be tempted to look at the wounds early, as this could increase your risk of infections. Absorbable stitches are used, so no stitches need to be removed. You can shower after 48 hours and then remove your dressings carefully. Please be gentle when drying yourself and ideally do not direct any water jet stream directly on the abdomen. Once you are home, gently increase exercise as symptoms allow. You do not need to confine yourself to bed. You can drive, but ability to do so varies between patients. You will be fit to drive if you can do an emergency stop without causing pain and feel confident driving the car. Please wait a minimum of 1 week before driving. It is worth informing your insurance company of your surgery and confirming with them that you are insured to drive again. You can return to work when you feel able. This is very much dependent upon the nature of your work and varies between patients. Some patients return to work after 1 week, others take 3 to 4 weeks. It is important to do light duties only to start with and to do no heavy lifting for 4 weeks, nothing heavier than a kettle of water. Please keep a note of when you return to work. On average, we know that patients return to work faster following this surgery than the open prostatectomy. Please wait at least 2 weeks to travel short-haul flights and 4 weeks to travel long-haul flights. These are just the minimum recommendations, and again, if you have any concerns, please delay your travel. Please also check with your insurance company before flying.
Hi, I'm David, one of the Urology Oncology Nurse Specialists. I'm going to talk you through catheter fundamental principles of care. A urinary catheter is a hollow plastic tube used to drain urine. It has 2 channels, one to drain urine from and the other to inflate a balloon. It is held in place by a water-inflated balloon that is inflated after insertion. The catheter is a very important part of your recovery. It protects the join, anastomosis between your bladder and water pipe in the early part of the healing process. Aim to drink 2 to 2.5 litres while it is in place. We like to leave this in for as short a time as possible, between 7 to 10 days after your operation. Removal of the catheter is very straightforward and only takes a matter of seconds. This has to be done in the urology department for safety reasons. Occasionally, your surgeon may make a decision to leave the catheter in for longer. If this happens to you, it will be explained to you. Please bring some spare clothes and incontinence pads just in case of urinary leakage. After insertion, the catheter is connected directly to a sterile drainage bag. If at all possible, one should avoid unnecessary disconnection of the drainage bag. Maintaining a closed system reduces the risks of associated catheter-acquired urinary tract infections. You will be shown how to use the catheter before you are discharged from hospital. Care of urethral catheters involves routine daily personal care to maintain meatal hygiene. Soap and water is all that is required. Using a disposable wet and soapy wipe, clean the head of the penis. Make sure to retract the foreskin to clean underneath, unless you're circumcised, and remove smegma, as this can increase risk of infection if left uncleaned.
I'm now going to give you a demonstration of the catheter drainage system. This is a leg bag which we have attached to the catheter for demonstration purposes. It is a smaller volume bag that can be attached to the leg using Velcro straps. This allows for maximum freedom of movement and can be concealed under clothes. The straps can be removed when you shower to prevent them from getting wet. It is attached directly to the catheter tube and should not be removed and will collect the urine as it is produced during the day. Use the tap at the end of the bag to empty your urine into the toilet when required. The tap is closed in the up position and open in the down position. The same as a zip on your trousers. Please empty this regularly throughout the day to avoid the bag becoming too heavy and pulling the catheter. This is the night bag. It is a larger capacity bag and can hold 2 to 4 litres of fluid. It is used post-operatively and as a night bag once you are at home. It can be connected directly onto the bottom of the leg bag. To attach the leg bag to the night bag, first wash and clean your hands thoroughly. Empty the leg bag as previously demonstrated and remove the protective cap on the night bag. Then, with the tap still open, insert the end of the night bag into the small piece of tubing at the end of the leg bag. Leave the leg bag open to allow for continuous drainage of urine from the leg bag into the night bag. The night bag can be attached to a nightstand or placed inside a clean washing up bowl. Make sure this is stored on the floor below you to allow adequate drainage. In the morning, turn off the tap at the bottom of the leg bag. Disconnect the night bag and empty the urine into the toilet from the night bag. And then rinse the night bag using warm, soapy water only. It can be used again for 7 consecutive nights. You will be given a supply of leg bags and night bags when you are discharged from hospital. The catheter is not to be flushed or clamped at any point whilst it is in place. If you have any concerns managing your catheter, please contact the hospital for guidance or go directly to the emergency care centre at Canterbury Hospital.
You'll be given tablets to stop stomach irritation to be taken for the first week and medication to prevent constipation. For men whom erectile function is important, a medication will be offered and should be started once the catheter is removed. We would recommend buying over-the-counter painkillers to have available as required during your recovery period. You will be required to self-administer an injection into your stomach for 28 days. This is a blood thinner that will help to prevent a blood clot. You will be taught how to do this on the ward before you leave hospital. You will be provided with exactly enough injections and a sharp spin to dispose of the used needles.
I'm now going to demonstrate how to administer the blood thinning injection we discussed earlier. This is given as an injection under the skin. The recommended site for injection is in the stomach area. You should alternate the injection site in the stomach area each day you administer the injection. First, wash your hands thoroughly. Remove the protective cover from the needle. You do not need to remove any air from the syringe. Pinch a fold of skin between your thumb and forefinger. Push the entire needle into the skin. Then press down the needle plunger to inject the drug. Keep the skin pinched the entire time you give the injection. A needle guard will eject to cover the needle once the plunger is fully depressed. Do not rub the injection site after the administration, even if this stings, as this will cause bruising. Once you have administered the injection, dispose of the empty syringe in the sharps box that has been provided to you.
Here is a list of the telephone numbers for you to arrange the disposal of your sharps bin. A paper copy of this list will be provided to you before the surgery. Please do not bring the used sharps bin to the hospital.
To summarise, please remember to watch out for excessive bruising or swelling. Please wear supportive garments. Pus or excessive leaking from wound sites. Offensive smelling urine. Bright red urine is a concern. Expect pink or clear urine. Ensure your catheter is draining well. Be aware of catheter blockage. And finally, expect abdominal tenderness and bloating. Erections will be affected by this surgery. This is more likely in older age groups and if you have weak erections before the surgery. In patients who want to regain their erections, there may be the possibility that we can offer nerve-sparing technique. This is part of the operation where we protect the nerves that go down to the penis. These run very close to the prostate and can be gently peeled off. We do not offer this in patients with more advanced disease. Your surgeon will discuss with you if appropriate. Even with nerve-sparing surgery, erections are not guaranteed. Even if you have no pre-existing problems with erectile function before the operation, that does not mean you will automatically regain function after surgery. Spontaneous recovery that is going to happen can take up to 2 years. We have dedicated clinics for erectile dysfunction that we can refer to you post-operatively if you require. Treatments for erectile dysfunction include maintaining a healthy weight, regular exercise, a low-fat diet, giving up smoking and regular pelvic floor exercises. Medical treatments aiming to improve the blood flow to erectile tissues are all free on the NHS. We have dedicated erectile dysfunction clinics at East Kent Hospital University Foundation Trust. You are started on low-dose medications for 6 weeks to aid erectile function recovery and to promote wound healing. Please be aware of the side effects. These can include headaches, indigestion, and a flushed face. Intolerance to these medications is indicated if you have the following associated symptoms: itchiness or swelling in the back of the nose, back or leg pain. Please stop taking this medication and discuss with your clinical nurse specialist or doctor if you experience any of these symptoms. Other treatments we offer include vacuum therapy device, alprostadil in various forms, topical, urethral suppository or intracavernosal injection. Please ask your CNS about these treatments to find out more information. Here is some data from our trust of the first 100 patients at 1 year after surgery. These results include patients who may use or may not use medical interventions to achieve an erection adequate for intercourse. At 6 months, 42% of patients were achieving satisfactory intercourse. At 12 months, 62% of patients were achieving satisfactory intercourse. At 12 months, only 38% of patients had not recovered erectile function. Outcomes for erectile dysfunction are measured up to 2 years after surgery.
Hello, my name is Holly and I'm a Urogynae physiotherapist. I'm part of the Kentcontinent team from Kent Community Health NHS Trust. It's important to understand what and where the pelvic floor is, what it does, how it is affected following radical prostatectomy surgery, and what you can do to help. The pelvic floor muscle is like a sling in the pelvis. It attaches to the pubic bone at the front and the coccyx at the back. Its first job is to support the internal organs, for example, the bladder and the bowel. Its main function is to maintain bladder and bowel control to keep you continent. Another important role of the pelvic floor muscle is for maintaining erectile function. Urinary incontinence, particularly stress incontinence, is a common but often temporary side effect of the radical prostatectomy. This is because both the bladder neck, which is the valve to stop urine leaving the bladder, is impaired, and the pelvic floor muscle is bruised and weakened during the surgery, meaning that urinary leaking is likely to happen on sudden movements, for example, coughing, sneezing, jumping, lifting, bending. Erectile dysfunction is also common to varying degrees. Therefore, strengthening the pelvic floor can help resolve both these issues. To locate your pelvic floor muscle, what I would like you to do first is to squeeze the back part of the muscle around your back passage and squeeze like you're trying to stop wind. Then I would like you to focus on the front part of the muscle. So imagine you're trying to lift your testicles or to try and stop a wee. Ideally, we would ask you to squeeze both the back and front part at the same time. That is how you squeeze your pelvic floor. You can check for yourself if you're doing these correctly at home by standing in front of a mirror with nothing on, and as you squeeze your pelvic floor muscles, you should see your scrotum lift and your penis retract slightly. Squeeze and lift for a count of 10 seconds, or whatever you can manage, and work towards that 10 seconds. That 10-second hold, I would like you to do 10 times in a row, and doing that 3 times a day. Those are the long holds. I would also like you to do the short squeezes, where you squeeze and release, squeeze and release. Doing that 10 times in a row, again 3 times a day. Make sure when you're doing these exercises that you're not holding your breath or pulling in your tummy or squeezing your thighs or your buttocks. Everything else should remain relaxed. We would like you to do these exercises in different positions. They don't all need to be done on the floor. You can do them sitting and indeed in standing. You can also try them whilst you're walking if you can. This may be harder in the early stages after surgery if your muscles are very weak. Another element of the pelvic floor training is practicing what we call the knack. This is the ability of the pelvic floor muscle to kick in just before those sudden movements that could cause leaking. For example, coughing, sneezing, lifting, bending. You may have to retrain this reflex. So for example, you're about to cough, so you would squeeze and lift the pelvic floor muscle just before, you'd cough and then let go after. Or when bending down to tie your shoelaces, getting in and out of the car. If you can get into the habit of practicing this now, prior to the surgery, you'll remember to do it afterwards as well. With regards to general exercise, it is good to get up and do brisk walking after the surgery. This helps to increase the blood flow to the area, aid healing and strengthen the muscles. Gently build up to your usual exercise level. Try to avoid too much heavy lifting or impact exercise, for example running or heavy weights in the early stages, particularly if you are still leaking. Wait until you're dry, which indicates that the muscles have recovered. We would recommend you avoid cycling for a few months after the surgery. This is because of the pressure on the perineum on the saddle, which can reduce the blood flow and slow the healing. So starting the exercises now, prior to the surgery, and then as soon as you have the catheter out, these will help you to regain bladder control and reduce incontinence, and also help to restore erectile function. There are some other things that you can do to help yourself if you are suffering from incontinence issues. Avoiding drinks that are bladder irritants, for example, drinks containing caffeine, so tea, coffee, hot chocolate, green tea. Fizzy drinks and alcohol can all irritate the bladder. Avoid constipation after the surgery, as any straining can weaken the pelvic floor muscles further. Ensure you do take the laxatives provided on discharge from the hospital. And also maintain a good bladder routine. By that I mean training the bladder to hold on longer between wees. Don't go unless you need to. And avoid those just-in-case trips to the toilet. We will contact you via telephone after your surgery to review your progress and individualise your exercises. We can then arrange a face-to-face appointment if required to progress your treatment.
Continence can be affected by this treatment. However, long-term incontinence that lasts longer than a year needs further surgical treatment is around 2 to 3%. The majority of patients will have some degree of incontinence when their catheter is removed and may need to use incontinence pads for a period of time. With robotic surgery, continence recovers quicker. The bladder has been artificially kept open by the catheter and is not used to being filled. This, combined with the body tissues at the site of the surgery being swollen, causing a loss of elasticity and a loss of full control of the flow of urine. This urine leak can occur after effort, exertion, exercise, coughing, sneezing, laughing or bending. This table outlines continence recovery and is taken from our audited results. At 1 week, 29% of our patients were continent. At 3 weeks, 47%. At 3 months, 72%. And at 6 months, 84%. And at 12 months, 92%. The Kentcontinent Service are a community support service. You are referred to the team automatically following surgery. They are an independent service and our trust have no control over the appointment scheduling. Their role is to discuss issues surrounding continence and assist with pelvic floor rehabilitation. Pads will be required and we advise you to buy these prior to your surgery. Remember to bring some along with you when the catheter is removed. If you require their support, the physio will see you at approximately 6 weeks. If, however, you are continent, please remember to cancel this appointment. You can self-refer by calling the number provided at any time in your recovery. You may qualify to have your incontinence products paid for by the NHS. This is determined by local commissioning groups and is dependent upon an assessment by a Kentcontinence team and meeting specific criteria. This is usually reserved for patients with chronic long-term conditions. If you would like to be assessed for funding for products, please contact the Kentcontinence team. To be prepared for your catheter removal and any potential temporary urine leakage, we advise that you purchase bladder weakness products. These are incontinence pads designed to be used at home for the duration of your continence recovery. You can purchase these products at any local pharmacy or supermarket. They come in a variety of shapes and sizes. Please ensure that you purchase the correct type of product. They are specifically designed to capture urine and to maximise discretion. They adopt different levels of absorbency and have a very straightforward guide to help you identify the absorbency of each pad. We recommend you purchase a heavy absorbency pad for the early part of your recovery and a medium absorbency pad. You may be pleasantly surprised at the speed at which you transition down the levels of pad absorbency, and therefore it may not be necessary to bulk buy lots of pads at the very beginning of your recovery.
You will have a date scheduled for the catheter to be removed 7 to 10 days after surgery. Remember, the medications for erectile function are to be started the day the catheter is removed and not before. You will be seen by your surgeon 6 weeks after surgery, then at 3 monthly intervals to check PSA levels. Please remember to have your PSA level taken 1 week before you see the surgeon. Please keep a note of when you stopped taking painkillers, your current activity level and number of daily pads used. Please remember, you will have abdominal discomfort, bruising, blood in your urine, erectile dysfunction, urinary incontinence. This is not normal for you, but very common after the surgery. If you have any concerns and would like advice, please contact your cancer nurse specialists on the number provided during normal working hours. Alternatively, outside working hours, you can contact Clark Ward for advice.
Your follow-up and risk of recurrence will be determined by the following essential results. These include the PSA, which is the prostate-specific antigen. This is a protein produced by the prostate gland and identified in the blood. Men with prostate cancer tend to have higher levels of PSA in their blood. However, some men with prostate cancer may have normal PSA levels. PSA levels can be increased by conditions other than cancer, and levels tend to increase naturally with age. After surgery, your PSA should fall to undetectable levels. The Gleason score, which is an internationally recognised grading system based on examination of tissue obtained by prostate biopsy. The pathologist allocates an overall cell abnormality score that can help predict prostate tumour progression. The scale runs from 6 to 10, with 6 often described as non-aggressive, 7 as moderately aggressive, and 8 to 10 as aggressive. And finally, the tumour node metastases classification, which is used to stage prostate cancer. It describes the extent of the primary tumour, or the T stage, the absence or presence of spread to nearby lymph nodes, the N stage, and the absence or presence of distant spread or metastases, the M stage. Here is a breakdown of the tumour stage. T1, which represents clinically unapparent tumour that is not detected by digital rectal examination or visible by imaging. T2, where the cancer is confined within the prostate. T3, where the cancer extends through the prostate capsule but has not spread to other organs. And T4, where the cancer is fixed or invades adjacent structures other than the seminal vesicles. It is important for you to know that regardless of your Gleason grade and clinical stage, the follow-up process will be the same, with regular PSA monitoring the central feature. You will be provided with questionnaires to fill out in preparation of your surgery and at certain time intervals set by your consultant. These focus on 3 core assessment subjects: quality of life, continence, and sexual function. To summarise, the purpose of this surgery is to remove the prostate and all the cancer. However, prostate cancer can spread microscopically outside the specimen that was removed. The risk of recurrence is dependent upon what clinical stage and grade your prostate cancer was when it was examined under the microscope. Your PSA level will give us biochemical guidance on whether there is cancer activity in your body. Your consultant will advise you about having further treatment such as hormones and/or radiotherapy to kill or control these cancer cells. If this is necessary, they will refer you to an oncologist that specialises in prostate cancer to guide you through further treatment. Your cancer nurse can provide you with advice and support if this happens to you. On behalf of myself, Wendy, Holly and the rest of the team, we would like to say thank you for taking the time to watch this presentation. We hope this has provided you with all the information needed, and if you have any further questions, then please do not hesitate to contact us using any of the details provided. We would also like to take this opportunity to say a special thank you to PCSA Kent, who made this whole presentation possible, and their continued support.